Thank you very much, Despina, and good afternoon, everybody. I'm really delighted to be here today and very grateful to Leigh Day for organising this important conference. The gender inequality in our society is expressed very strongly in the starkly unequal health outcomes for men, between men and women. While women in the UK live on average longer than men, they spend a significantly larger proportion of their lives in poor health. Poorer treatment and outcomes are well documented, as we've been hearing today, whether in the UCL study that found that women with dementia experience worse medical treatment than men with the same condition, or the study that found that women make fewer visits to the GP, receive less health monitoring and are more likely to be taking harmful medication, or, as we've been hearing from Sarah, the burden of menstrual problems from severe period pains to PMS to endometriosis, for which diagnosis is often slow, treatment is often poor, and the level of pain women are routinely expected to tolerate and continue to function in their daily lives is unacceptable. We also understand, because it is well documented, that the causes of these inequalities are structural. Women are underrepresented in clinical trials, the health conditions which are specific to women are under-researched, and women report that they are often not listened to when raising concerns about their own bodies. I want also to acknowledge that this gender disparity in health outcomes is compounded when there is an intersection with other inequalities, illustrated in the shocking figure that women in the most deprived areas of the country have on average 20 years fewer of good health than women in the least deprived areas, and in the heartbreaking and unacceptable disparity in outcomes for Black women in pregnancy and childbirth. And there are many other examples of those intersections that we can think of. But I am here today to speak about the experience of my constituent, also my friend. She needs to remain anonymous for legal reasons, so I will call her Sarah for the purposes of today. Sarah is a young woman in her 40s with gorgeous 5-year-old twins. Just over a year ago, she received a shock diagnosis of stage 4 bowel cancer, which had metastasized to her liver. Sarah had always been fit and healthy and had been under the care of GPs. The news of her diagnosis was, as you can all imagine, very hard to hear. Sarah believes that her gender, age, and being a relatively new mother all contributed to her late diagnosis, and she sets out 4 different types of evidence for this. First, Sarah had been going to her GP with symptoms related to iron anemia for a long time prior to her diagnosis. She had a diagnosis of iron anemia which persisted and worsened over time, but which did not lead to any further tests. Sarah's iron anemia was apparently not of concern to her GPs because she had recently given birth to twins and because she was a woman of menstruating age. It was dismissed as being due to heavy periods, despite the fact that she was never asked any objective questions, such as how often she needed to change her period protection. It seems likely that had she been a menopausal woman or a man, her doctors might well have investigated the cause of the iron anemia rather than making assumptions about its cause. Second, Sarah explains that as a new mother, your body goes through many changes. It's not always easy for new mothers to know what is normal. That should place even more of a responsibility on medical professionals to investigate and get to the bottom of abnormal blood results. In Sarah's case, doctors failed to act on the red flag of iron anemia. Third, Sarah highlights that it is too easy for doctors to dismiss symptoms which may together indicate a more serious medical condition, simply as part of the stresses and strains of life. Many women experience a difficult return to work after childbirth. Being a new parent is exhausting, and juggling new responsibilities can be stressful. In Sarah's case, symptoms such as fatigue, low mood, and an irritable bowel were all explained away in this context, rather than being seen as symptoms which required further investigation. Finally, Sarah highlights that she experienced an inbuilt assumption by many different medical professionals that she was simply too young to get bowel cancer. She has told me that many medics have remarked on how well she looks, even following her stage 4 diagnosis. Others have told her that she seems too young for bowel cancer. There is an ignorance behind these assumptions because the numbers of young people being diagnosed with bowel cancer are increasing both in the UK and internationally. Early diagnosis is the only key to improving survival rates for bowel cancer. There is a stark difference in the 5-year survival rate, which is 92% for stage 1 diagnosis and just 10% for stage 4. Sarah's persistent iron anemia should have resulted in her GP ordering a FIT, a fecal immunochemical test, which tests for blood in your poo. This would have identified her cancer at a stage at which it was potentially curable. It is heartbreaking for Sarah and her family to know that the incurable diagnosis she now faces could have been different. The time that she will have to spend with her young twins in any scenario will be limited because of the failure of GPs to order a simple, cheap and available test. NICE guidelines say that FIT should be used to test people under the age of 55 where iron anemia is present. While these are only guidelines, they represent best practice. The increase in diagnosis of bowel cancer in young people certainly gives rise to a question about whether the age of the national screening programme should be reduced. That is a matter for clinical research and judgment, but in the meantime, more should be done to ensure that there isn't a postcode lottery on the use of FIT and that all GPs are aware that it should be used for younger patients with iron anemia. It should also be the case that persistent iron anemia is one of the common red flag symptoms for bowel cancer, which patients are told about within public health messaging. Sarah had followed the incredible campaigning work of Deborah James on bowel cancer symptoms, but they didn't mention iron anemia. She hadn't heard of a FIT test and didn't know that this was something that she could have asked for. In Sarah's case, there appear to have been multiple reasons contributing to her devastating late diagnosis. The dismissal of symptoms as part of new motherhood or normal menstrual bleeding, an inbuilt but incorrect assumption that she was too young for bowel cancer, a lack of awareness of NICE guidelines relating to FIT, and a lack of curiosity on the part of GPs about why this otherwise fit and healthy young woman was suddenly and persistently presenting with ill health. I would say that the issue of lack of curiosity by doctors as to the underlying cause of a patient's symptoms is a factor in at least 3 other constituents who I am aware of who have had a devastating late-stage cancer diagnosis at a relatively young age. That is not an issue which is specific to bowel cancer. The cases I'm aware of involve prostate cancer, breast cancer and leukemia, but it is an issue which I think warrants particular attention. Ultimately, if we are to reduce inequalities in women's health, we need to dig into the detail of the experiences of women like my constituent Sarah who have been failed. And we need to use these cases to establish the structural changes in clinical culture and practice which are required to make a difference. I'm grateful to Despina and Leigh Day for the support that they are providing to Sarah as she seeks accountability for the ways in which she has been failed. I hope, as I know Sarah herself does, that her devastating case can be used to drive change from which other women can benefit.